So hello everyone. So here we will discuss on the proning in ECMO, a rebuttal. What we need to do, what we need to consider, and what are the drawbacks on proning a person in ECMO, and what are the evidences here. We all know that the purpose of VV ECMO is to rest the lungs, to reduce the ventilator supports. We have multiple guidelines put forward by many bodies, for example, also how to use the ventilator support. And we should also consider that it's just a supportive therapy and it is not a treatment per se. Most importantly, why we use ECMO? ECMO helps in VV ECMO in particular helps in increasing the oxygenation. And we have two trials with this. One is Caesar trial, which has shown the definite mortality benefit for both clinical and statistical. However, it has not been same reciprocated in the Eolia trial. So what does the proning does? What it requires? Again, we have considered in the previous slides, we have discussed that the ECMO increases the oxygenation. Same here, proning improves the oxygenation on the basis of physiology. In non-ECMO and non-COVID patients, it has increased, it has reduced the mortality, it has shown benefits as discussed in the ProSiva 2013. What does it need? It needs increased use of sedatives and paralysis. It is a laborious job. It needs multiple people to be involved to turn the patients, and it needs a proper coordinations. And definitely it is associated with the complications such as hemodynamic instability. If the person is on multiple vasopressor supports, you definitely cannot prone the patient. It can cause hemodynamic instability. It will cause kinking of the tubes. For example, kinking of the ET tube, CVC line may come out, PVC line may kink out. Dialysis, if the person is on dialysis, then the dialysis catheter may get kinked. It will cause the nerve injuries. It will cause the globe injuries. It may increase the ICPs. If you cannot do in the persons like who underwent abdominal surgery or the person who is having an abdominal compartment syndrome, since it is known to increase the unstable pelvic hematomas, unstable pelvic fractures, or the long bone fractures, etc. So we need to consider these things while proning the patients. Proning itself is a laborious job. You can imagine how laborious it would be when the person is on ECMO. Not only will be on multiple catheters, we need to put we have also the access and the drainage cannula in place. Those are very much pressure dependent. We have seen in many YouTube videos, many YouTube lectures, or many other literatures where they have shown that the ECMO patients playing basketballs, playing guns, extubating the patients on ECMO. Yes, we have seen. In fact, we did it in our institute. But however, we should also consider that what was the condition of the patients when he on ECMO, when he was mobilized, when he was extubated. Definitely, those kind of patients will be stable. So here we are talking, when we are talking about the proning in ECMO, that means the person is not stable. His lungs are not stable. He cannot be extubated. Okay, he cannot be mobilized, right? So definitely the patient is fragile. Greater the fragility of the patient, more complications are to be expected. How to perform a proning? It's definitely like throwing a cannonball. It's just like a circus where multiple teams are involved. Proper coordination amongst the all staff is necessary. One person should look into the cannula, IJV cannula, and then he should also, if he's well versed enough, he can also take care of your tube, ET tube. If not, one more person has to come. Secondly, when we should take the femoral cannula, should take care of the femoral cannula, and then other tubes like your femoral catheters and all those things. And 3 to 5 persons, based on the BMI of the patient, build of the patient, needs to be done. So where we need to turn, whether we need to turn the patient to the left side or to the right side, it is itself in a dilemma. Some say wherever there is a catheter, right IJV, if the person is having the drainage cannula from the right IJV, that thing should be above. That means we need to turn the patient to the left side. So it's all a juggling. It's like a juggling in a person, proning a person with ECMO. It's like a juggling. It requires proper coordination and all. So we are ready to do it. but what will I get in return? My basic question is this: will my patient survive? What are the odds that he will not have any complications? What are the odds that these catheters will not get out? What are the odds that he will not have a kinking of the catheter, access cannula, drainage cannula, which will lead to a lot of catastrophic events? And what are the evidences? What are the evidences right now, presently, regarding proning with ECMO? Before we go into evidences, we should look at why Prosiva was successful. In this scenario, when a study done by the Gattinoni et al. In the year 2001, look here, they were using the tidal volume of 10 ml per kg. Whereas the Prosiva done in 2013, thanks to ARDS net protocol and ARMA trial, they showed the benefit of low tidal volume. Here in 2013, they have used the low tidal volume. Therefore, that will be the one of the reasons for the success of the Prosiva. It's like a mixing, it's like a cooking with the proper ingredients. Had we done the Prosiva with 10 ml per kg, we couldn't have got the result. So similarly, the PEEP. See, the Gattinoni et al., Guerin et al., they have used the higher PEEPs. Here in the Prosiva, they have used 6 PEEP, 6 centimeters of water plus or minus 1. So it's like a proper Prosiva movement we need. Therefore, the Prosiva got success. What are the Prosiva? Do we have a Prosiva movements in the proning plus ECMO? What are the evidences? There are multiple evidences which I am going to show in the following slides. In one of those, most of the things are most of them are retrospective or some are prospective. But they have not, in all these studies, they have not fixed the duration of the proning. Some say duration of 7 hours, some say 6 hours, some say median of 8 hours. We don't know what exactly the duration of proning should be. And we definitely don't know when it has to be started. For example, Prosiva 2013, they said that if the PF ratio is less than 150, please prone. That too within 36 hours. We routinely do not do that. We usually prone the patient between 2 to 5 days after initiation of the mechanical ventilation. Here in proning with ECMO, we don't know when to start. ECMO initiation per se will happen between 2nd day to 14 days. After the ECMO initiation, when we need to start the proning, for how long we need to continue? Do we have those evidences? Presently, evidences are scarce. We don't have. And the complications associated, though there are many minor complications like kinking, hemorrhages, and all, most of the evidences or the studies that have been done show that proning in ECMO is safe, with negating some minor complications. One study has shown the hospital survival, which is done by the Riedlinger et al., which is again, here it's a retrospective cohort trial, and the initiation of proning of the person after initiation is 1.7 days, and the median duration was 19.5 hours. There is a subgroup analysis which showed the mortality benefit. Coming to the proning in ECMO, that is a Prone-ECMO trial. This has been the latest trial which is buzzing around the market, which showed that there is no conclusive evidences in patients with severe ADS who have been proned on VV ECMO. So there is no statistical or clinical or the mortality benefit. Although there are certain caveats, like 84% of the patients were COVID. We know that the COVID patients with the ECMO, with the proning, are not beneficial per se. So these are the caveats with the prone ECMO, but however, the physiology remains the same. So current evidences are that there are totally 12 observational studies, of which 11 are retrospective trials. Only 6 with comparison arms. 3 were propensity matched. Only 3 were multi-centered. You can see the level of evidences that we have, which is very scarce. And pre-pone duration noted in 7 studies was more, median days was 4.9. But definitely we don't have the standard outcomes measured. So as discussed earlier, we don't have the proper time to initiation. We don't have how long we need to view. We don't know how long we need to view the sessions, for how many times we need to do the sessions. So definitely there is no Prosiva movement for the proning with ECMO right now. So these are my basic questions. Again, I'm ready to do the juggling. When to begin? Does anybody has an answer? No, no evidences has right now. For how long? No evidences. On whom? whether I can I get the severe ARDS, whether can I do it on the ECMO patient, COVID patients, how does it go? We don't know, right? There is no proper objective measures. So why we are not having that procedure moment with the person in the Prone-ECMO is that in this slide, we can see that there are heterogeneous tidal volume being delivered in the patients with the mechanical ventilator on patients in ECMO. Some have given the ultra-lung protective ventilations of less than 4 ml per kg. Some have given 4 to 6 ml per kg. Some 7 to 9 ml per kg. Again, there is a heterogeneity in the PEEP being delivered. Some give less than 5, some give 6 to 10, some 12, some 16. So there is no heterogeneity. So that proper ingredients are not yet fixed. Therefore, we are not getting any procedure moment, or we are not getting any mortality benefit. So in this discussion, we got to know that there is an improvement in the oxygenation. Possibly your physiology is helping us. There's a physiological gain, and there is an improvement in the compliance. What about odds of survival? Do we have any records? Do we have any evidences? No. Again, what we need to consider is again the risk versus benefit. Definitely, there are evidences. There are based on this discussion, proning is not that harmful in person ECMO. But if everything is failing, please consider proning. One more logical question is that if a person comes with ARDS, we initially do with the positive pressure ventilation through the non-NIV. We go with the pressure targeted. We go with the application of PEEP. We prevent the alveolar collapse. We prevent the volume overload. After everything fails, we initiate the invasive mechanical ventilation. Again, here we start with the pressure targeted ventilations. Despite all these measures, if there is no improvement in the oxygenation, we consider proning. Again, if the proning fails, then what is the next option? That means if my physiology is failing, then we need to consider the ECMO. Now, despite this ECMO, despite proning, after failing of the proning, we have initiated ECMO. Despite this failed oxygenation on the ECMO, what is the logic behind proning the same patient? Still, there is still a big question mark which I need to ask the listeners here. My take-home message would be, ECMO was used as a last resort despite proning in acute respiratory failure. We should consider proning in ECMO when as a last resort if the ECMO itself is proning. As we know that more RCTs and more evidences are needed for this novel approach. Thank you.